This is coding night 5, the first half of our session. And we are on page 54 of the coding workbook. And we finished our lab last week by beginning to talk about procedures, and so we're going to do that some more. I think you're pretty well briefed on how the procedure index is divided. If you're not sure how it's divided, that's labeled Format and Organization on page 54. And remember that the procedure index has both an alphabetic and a tabular, just like the diagnosis index does. And there is a way to code every single procedure that you could possibly give to a patient. However, do you necessarily want to code every single procedure? No. In a hospital setting, would you want to code every chest x-ray?
Yes.
Would you?
Oh, no,
No, not a chest x-ray. Would you want to code a carotid arteriogram?
Yes.
Yeah, well, what's the difference? Why would you do one and not do the other?
That, what do you call that, Mama? The last one. You said carotid who?
A carotid arteriogram. That's the one where they inject some dye into your carotid.
That's why you always say, well, that's an injection.
That injection would be invasive. So anything that is invasive of any type, you definitely want to code. And, you can code every single lab test you can do to somebody, but you wouldn't want to do that in a hospital setting. Couple of reasons. One is it's taking up space that other more definitive procedures could use. And the other thing is that in your system, when you make a charge for a lab test, doesn't the fact that you made a charge for that particular lab test indicate to you that that lab test was done? So it'd really be like double coding it, wouldn't it? So anything that you're not already picking up in the system, you want to look twice at as to whether you're coding it. But of course, if it's considered a procedure, a significant procedure, then you will code it. Take a look at the second paragraph there. Most of your chapters deal with a specific body system, just as they do in the diagnosis index. There are 4 exceptions, and these are the chapters listed for you in your book, and they're specific to certain areas. It's not important that you know what they are. All right, take a look at the last paragraph. Procedure codes look different than diagnosis codes because procedure codes have either 3 or 4 digits with 2 digits preceding a decimal and 1 or 2 digits following the decimal. So diagnosis codes can be as long as 3 digits, decimal, 2 digits. Procedure codes can only be as long as 2 digits, decimal, 2 digits. So that's the biggest difference. If you can remember that the procedure codes are in their longest fashion are 1 decimal short or 1 digit shorter than a diagnosis code. And that means that when you look at it, you should be able to tell the difference. Will a procedure code ever have 3 digits, then a decimal? No. That's the way to tell. So if it's got 3 digits and a decimal, it's a diagnosis code. If it's got 2 digits and a decimal, it's a procedure code. All right, we have conventions or rules that deal with the procedure indexes as well. They're not difficult. They're the only one that's really important as far as the book is concerned is the instruction to code also. There is one other instruction you'll occasionally come across, and that is omit code. And so you may want to jot that down. If you happen to look up something and it says omit code, then don't code it. It's just that simple. If you look up something and it says code also, then it means there's something else that if it's a part of this procedure, you must also code it. For example, take a look in your book at the bottom where it says 13.1, an intracapsular extraction of a lens. This is talking about cataract surgery. It says to code also any synchronous insertion of a pseudophacus. All right, you've got a cataract, which means that the natural lens of your eye has become cloudy. You can't see through it. So they go in, they make a little tiny incision, they suck that natural lens out. Well, if in the course of that surgery they implant a new synthetic lens, then this is telling you code also any synchronous, meaning done at the same time, insertion of pseudo. What does pseudo mean? False. And phacos means lens. So if you're putting in a false lens at the same time you've intracapsularly extracted the lens, then you're going to have two codes, aren't you? So watch for the code also. The second example at the top of page 55 is that you'll have a code also instruction when you've got to have another code under certain adjunct types of procedures where they go hand in hand with one another. You can't do one without the other. An example would be if you are going to have any heart valve surgery. They're going to put you on a cardiopulmonary bypass machine, aren't they? They just are, because they can't very well operate on the inside of your heart without bypassing the heart, because they've got to do something with the blood supply so that they can actually get into the inside of the heart. So there's an instruction there to tell you to code also the cardiopulmonary bypass. A heart-lung machine. So every time you are using a heart-lung machine for any procedure, there's a separate code that you'll add to it. How do you go about looking up the codes? The best thing for you to do is look for the name of the procedure. If it calls it a revision, you look up revision. If it says insertion, look up insertion. If it says resection, look up resection. Look up the exact words that you're given. Now, once in a while, they're going to fail you. And that's when you have to go to alternative wording. You might have to do, instead of excision of, you might have to go to removal of. But that's pretty synonymous, and after a while, those words will come to mind after you've looked up something long enough. And we'll have some exercises on that. Eponyms. Eponyms are terms that are named for someone. Now, we have eponyms in the diagnostic index as well as the procedure index. You may have heard of tetralogy of Fallot, Wilms tumor, Hodgkin's disease. All right, those are diagnostic eponyms. They are named for someone. We also do have them in the procedure index, like Davis operation, ureterotomy, a Roux-en-Y. All of those are procedures that are named for someone, and you will just simply look them up exactly as the words given you. So the best rule of thumb is always to use the words the doctor gave you. Then if those words fail you, start looking for alternative wording. Now the bottom of page 55, this takes just a little bit of explanation. It's not hard if you just kind of stop and think through it. Removal of an organ. All right, that's taking out the whole darn thing, isn't it? Mm-hmm. All right, when you see removal of an organ, that's generally going to be categorized as being an excision or a resection. If I excise the stomach, what have I done to the stomach? Taken the whole thing out. If I do a resection of the intestine, what have I done? To resect means to cut into. So if I've got this long intestine, and right in the middle of it I've got some cancer, I go in there and I chop the cancer out and I put the two ends together. I have resected that, haven't I? But I've taken out the whole. All right, but that's when the resection, and especially the excision, deals more with taking out the whole. But a lot of times you'll have a problem with an organ and they don't take out the whole organ. Instead,